or not known, the bile buildup in the liver will be entered into the bloodstream and it will cause this condition obstetric cholestasis. Then some of the etiological factors are hormonal functions, genetic causes and environmental factors. Then in hormonal functions, the pregnancy hormones rise in the late trimester of the pregnancy. It may slow the flow of bile from the liver and gallbladder. It may lead to obstruction in the circulation and it will lead to obstetric cholestasis. Then the genetic causes, sometimes it will occur through hereditary. Certain gene changes also makes these conditions. Then certain environmental factors for obstetric cholestasis, in that seasonal variations in the environment. Commonly in the winter season, this condition may seen in pregnant women. Then reduced exposure to sunlight also leads to obstetric cholestasis, and these factors are not clear. It will be varies according to the geographical areas. So we can see the etiological factors are most commonly hormonal functions, genetic causes and environmental factors. Then some of the risk factors are family history of cholestasis. Those who have the history of family history of cholestasis, that may come to next generation also. Then history of liver damage, hepatitis C, gallbladder stone, these also risk factors for obstetric cholestasis. And in case of multiple pregnancy, there will be more production of hormones in the late trimester. That is also will lead to obstetric cholestasis. And the late pregnancy, that means more than 35 years of old, that elderly primary gravidas also risk for obstetric cholestasis. Next, what are the symptoms of obstetric cholestasis? The major symptoms are severe itching or pruritus. Itching starts on hands and feet and spread to other body parts. The itching is usually worse at night. Rashes may or may not be present during the time of itching. Then less common symptoms are the mother may feel nausea, dark urine, light grey or pale brown poo, extreme tiredness, decreased appetite, pain in the upper right of abdomen or belly, jaundice. How we can find it out? How we can diagnose obstetric cholestasis? Assess the symptoms through physical examination and antenatal assessment, and we can do liver function test. In liver function test, transaminase enzyme will be moderately elevated in case of obstetric cholestasis, and alkaline phosphatase also will be elevated in case of obstetric cholestasis. Then gamma glutamyl trans peptidase rise to more than 20%, and bilirubin also will be elevated in case of obstetric cholestasis. And the serum bile acid will be elevated and primary bile acid will be increased. Then we can see what are the maternal complications and fetal complications of obstetric cholestasis. The maternal complications are liver and biliary tree cancer. The mother may affect with the liver and biliary tree cancer. Then thyroid diseases, diabetes and cardiovascular disorders are the maternal complications. Then fetal complications are fetal growth restrictions. Actually, more than the mother, the child will be most seriously affected by obstetric cholestasis. Then fetal growth restriction may see in fetus. Then premature birth, heart arrhythmia, fetal distress, stillbirth, neonatal respiratory distress syndrome and meconium stained amniotic fluid. Then how we can cope up with obstetric cholestasis in pregnancy? Then what are the treatments we can see in obstetric cholestasis? The goals of treatment for cholestasis of pregnancy are to ease itching and prevent complications. For itching, we can use certain medications. These medications will help to lower the level of bile acids in our blood. It is used to dissolve the gallstones. Then azodiol is also used to prevent the formation of gallstones in overnight. People who are losing weight very quickly. Other medicines to relieve itching. Then soaking itchy area in cool or lukewarm water. Wearing soft and loose fitting clothes and provide adequate rest and sleep for the affected mothers. Then we should Frequently do the fetal monitoring in that non-stress testing, then ultrasound evaluation, and also we should check biophysical profile of the fetus. Then daily fetal movement chart we should use to record the number of fetal movements. Then up to 36 to 37 weeks induction of labor we can do. Less than 36 weeks steroid management should be given for the lung maturity of the fetus. Beta-metazoline injection and is given as 2 doses that are 24 hours apart for the lung maturity of the fetus in case of less than 36 weeks. Then some of the related research studies which is related with the obstetric cholestasis. There is a study of outcome of pregnancy complicated by obstetric cholestasis in 2014 to 2015 in Vivekananda Institute of Medical Science, Kolkata, West Bengal, India. Over 100 pregnant ladies suffering from pruritus and detected as having obstetric cholestasis. They were followed up and maternal as well as fetal neonatal outcome recorded. The incidence of obstetric cholestasis in hospital was 9.9. Majority of the cases are diagnosed in late gestational age, mostly during 28 to 32 weeks periods of gestation. The maternal morbidities are due to sleep disturbances, dyslipidemia, coagulation abnormality, postpartum hemorrhage, and increased chance of operative delivery. Neonatal morbidities are mainly due to fetal distress, prematurity, low birth weight, and meconium stained amniotic fluid. Maximum number of patients are delivered at 37 to 38 weeks due to active and early interventions. Then a study which is related to obstetric outcome during an era of active management of obstetric cholestasis conducted by Dr. Nalini Sharma, Shillong, Meghalaya, and the incidence of ICP was 2.4%. More than 86% of patients presented with generalized pruritus, mostly after 30 weeks. Incidence of intrapartum abnormal cardiotopography, that is 12.5%, and thick meconium were high. Cesarean section rate was very high, 41.66%. And some of the other studies which is related to obstetric cholestasis, a study related to maternal and perinatal outcome in pregnancy complicated by intrahepatic cholestasis conducted in All India Institute of Medical Science, Jodhpur. The result shows that 152 patients were diagnosed with the intrahepatic cholestasis in pregnancy out of 4,148 deliveries with a prevalence of 3.6. Among these, 140 had mild and 10 had moderate and 2 had severe intrahepatic cholestasis in pregnancy. There was a significant difference between the birth weight in mild, moderate and severe IHCP